Hi, my name is Melissa Riddle from the Iowa Cancer Registry. This presentation will focus on the SEER Program Coding and Staging Manual 2024 updates. During this presentation, we will review new data items for 2024 and understand the updates that have occurred for 2024. The location of these updates will be found on the SEER website. I will be reviewing major changes and not the minor updates or text changes. Please review the summary of changes noted here with a star prior to abstracting cases for 2024. Also, we will not be reviewing the 2024 STOR changes or updates. I will point out areas where there are differences in the manuals, and the maroon symbol shown here on the slide will note those differences when we come upon them, and I will discuss them. But you should always check, if you are a COC facility, the STOR manual as well. But SEER program standards and their abstracting standards are the priority for us. The new data items that we'll be looking over are geocoding, tumor size summary, and breast reconstruction codes. There are two new geocode data items which are derived. This means that abstractors will not be entering this information, but it will be based upon the address information and other information such as that is used to geocode cases. The geocoding quality code is used to describe the geocoding match, and the geocoding quality detail provides the details of the elements related to the quality of the geocode. Both data items have been available in the NACER geocoder since 2017. And the first request for the NACER call for data was in December of 2022. These codes provide researchers and registry staff a detailed assessment of the address components geocoded and the quality of the geocode. The codes provide a way to assess input reference data agreement, geographic accuracy, and microscale fitness for use at the sub-county level. Again, these are derived items and will not be coded by abstractors. New data item tumor size summary has the same instructions as the STOR manual. Tumor size clinical and tumor size pathologic have been removed and replaced by this data item, tumor size summary. This data item applies to cases diagnosed 2024 and forward. Previously diagnosed or historical cases will continue to be collected under tumor size clinical and tumor size pathologic. Tumor size summary is recorded in millimeters, and the priority order for recording tumor size summary are as follows. The surgical resection specimen or path report, when the patient has no neoadjuvant therapy, is taken as priority. If there is discrepancy among the tumor size measurements in various sections of the path report, code the size from the synoptic report. Only a text report is available, then use the final diagnosis, then microscopic or gross exam. If neoadjuvant therapy is performed and it's followed by surgery, code the largest size of the tumor prior to treatment beginning. Do not record the size from the pathologic specimen. If there's no surgical resection, code the largest measurement of tumor from imaging, physical exam, or other diagnostic procedures in this specific order. This again is prior to any treatment. If none of the above apply, code the largest size from all information within 4 months of diagnosis in the absence of disease progression. Continuing with tumor size summary, this slide is showing us how we are to code the tumor size summary if we are not given a specific size. So these are instances when we have the tumor size stated as less than X millimeters or X centimeters. Then we need to report this as 1 millimeter less. An example of this is less than 1 centimeter, code as 009. If you have a case where it is stated that it's less than 1 millimeter, code as 001. If a tumor size is stated as greater than X millimeters or X centimeters, report it as 1 millimeter more. So an example of this is if it's greater than 10 millimeters or greater than 1 centimeter, coded as 011. If anything is greater than 989 millimeters or 98.9 centimeters, coded as 989. When you have a tumor size that falls between two sizes, so you have something between 2 and 3 centimeters, then you'll record the size as the midpoint between the two. To do this, you add the sizes and then divide by 2. So our example here is the tumor size is stated to be between 2 and 3 centimeters. We code this 025. And how we arrive at that is that we take the 2 plus the 3, which gives us 5. We divide the 5 by 2, which gives us 2.5 centimeters, and we record that as 025. If it is given to us in a range, then we want to record the higher tumor size. So if the tumor size is 8 to 10 millimeters, then we would code 010, the 10 millimeter size, the higher size. And when you are given fractions of a millimeter, then we are to round the tumor size. We round to the tenths of millimeters in the 1 to 4 range down to the nearest whole millimeter. And for those that are in the 5 to 9 range, we round up to the nearest whole millimeter. The exception here for rounding is for breast sites. Sizes greater than 1 millimeter and up to 2.4 millimeters, we code that to 2 millimeters, 002. Again, review the SEER program manual for all instructions on coding tumor size summary accurately. The field derived summary grade has been added for 2024 and will be calculated at the central registry level for all cases diagnosed 2018 and later. This information will be coming from the grade clinical and grade pathological data items. The highest grade or more severe value will be taken from grade clinical or grade pathological to be used for derived summary grade, except for breast because behavior affects the priority. If grade is needed in the EOD 2018 derived stage group calculation, the value will also be used there. So it is very vital that we are accurately recording our grade clinical and grade pathological during abstracting time frame, as this will be what is pulled for derived summary grade. Breast reconstruction codes have been added for 2024. These are the same instructions as found in the STOR 2024 data item RX Sum Recon Breast. For the diagnosis years 2022 and 2023, the COC collected this information in the data items RX HOSP and RX Sum Recon Breast based in STOR manual. This is now collected by all standard setters beginning in 2024. We will code this for breast primaries diagnosed 2024 and forward. This reconstruction procedure must be immediately following the resection of the breast, so this is the same operative procedure or under the same anesthesia. You may have two reports where one surgeon performs the resection and another typically performs the reconstruction. This could be in a breast plastic reconstructive note, and oncoplastic surgery is typically performed by the surgeon, so it may be on one report. However, it could be on a second report, so look for a breast plastic reconstruction note as well. And this code only applies to the ipsilateral reconstruction, the reconstruction to the primary breast that is involved. This table shows the breast reconstruction codes. If there is no immediate reconstruction to the ipsilateral breast, or it was started but not yet completed, code A000. When just a tissue expander is placed without a permanent implant or without tissue, code A100. If a permanent implant or direct to implant occurs, then use code A200. Oncoplastic surgery is rebuilding the breast tissue after breast cancer resection, as it is a way to reconstruct and reshape the breast after lumpectomy or mastectomy. It involves rearranging of breast tissue to correct the breast defect. This can sometimes be found in the plastics operative report. The three codes dealing with these types of reconstruction are A300 when the breast tissue is rearranged, a parenchymal flap is placed, or there is adjacent tissue transferred without a formal mastopexy or reduction. A400 is when a formal reduction or mastopexy is performed or a breast lift. And A500 is reconstruction using regional tissue flaps or skin flaps. Codes A600 through A640 are used when immediate reconstruction using autologous tissue, which means tissue from the patient following a mastectomy. When the type of tissue isn't specified, use code A600. If you know the area in which the tissue was taken from the patient for reconstruction, then code what is specified, such as A610 if it comes from abdominal tissue, or A620 if it is from thigh tissue, A630 if it's from gluteal tissue, or A640 if it's from tissue from the back. These breast reconstruction codes are the not otherwise specified or unknown reconstruction codes when others don't fit or apply. So reconstruction performed but method is unknown is A900. Implant-based reconstruction NOS, so it did not fit any of the other codes, is A970. If all that you know is that an autologous tissue-based reconstruction was done and you cannot code it to the A600 range, then A980. And if it's unknown if immediate reconstruction was performed during the same operative procedure, code A990. Now we're going to take some time to look at the updates for 2024. These are updates to coding instructions and or data items. Here you see we have the symbol denoting a difference between SEER and STOR for both of these data items. Follow the SEER instructions as those take precedence over STOR. For recording Social Security number, the coding instruction number 2 has been added. This tells us to enter nines or leave blank for missing numbers of a Social Security number. Which one that is used, 9 or blank, will depend upon the registry software. For SEER ABS, we need to enter nines for missing digits. So the example here is all that we know are the last 4 digits. Then we would enter 999991234 for our missing Social Security information. If you use other software, you will need to check with that software vendor to know how you should proceed and enter the information for missing digits in a Social Security number. For laterality, when it comes to coding bilateral involvement, which is code 4, this has been updated to include bilateral breast involvement with inflammatory carcinoma, and this is 4E. Also, there is a bilateral involvement of a paired site, and it is unknown which side it originated. Again, use code 4, and this is 4F. So both of these were added to coding as bilateral involvement for laterality, when both sides of a paired site are involved and you don't know which side it began on. The example here is both arms are involved with Kaposi sarcoma and no other sites are involved, and it's unknown which arm the Kaposi sarcoma originated. We would assign the laterality to 4, bilateral involvement. For the data item tobacco use smoking status, this is the same as the STOR 2024 instruction. In SEER ABS, this data item is labeled as tobacco use, and for SEER, it is required as available. Tobacco smoking history can be obtained from the sections such as nursing interview guide, flowchart, vital status, or nursing assessment section, or other available sources from the patient's hospital medical record or physician record. This is for documenting tobacco smoking status, which includes cigarette, cigar, and/or pipe. And it does not capture marijuana, chewing tobacco, e-cigarettes, or vaping devices. The following instructions were updated as well. So for Code 1, current smoker, Instruction 3B now includes when you only have a statement of current tobacco use. Use Code 1. For Code 2, former smoker, Instruction 4B was added, stating prior tobacco use. Code 2. For Code 3, smoker, current status unknown, Instruction 5C has been included. It cannot be determined whether the patient currently smokes or formerly smokes. So in the medical record only indicates a yes for smoking without further information. And for Code 9, unknown if ever smoked, Instructions 6B states smoking status is not stated or provided, and 6C was also added. The method, cigarette, pipe, and cigar, used cannot be verified in the chart. Then you would code 9. Also, be sure that you use text fields to explain the code assignment per instruction 7. Again, this is required as available. So if you have the information in the medical record, please be sure that you are completing this information in SEER ABS and whatever else your software vendor has available for this. In the SEER manual, primary site had a few updates. These are not in the STOR manual. A new section regarding a physician priority order for coding primary site for solid tumors states that generally the surgeon is in a better position to determine the site of origin since they are visualizing the entire op field and not just a portion or piece at a time. Likewise, if an entire organ is removed and submitted to pathology, then the pathologist may be able to pinpoint the site of origin. So for this, if the entire organ is not removed, then review the op report to see what the surgeon is stating as the primary site. If the entire organ is removed and sent to pathology, then maybe review to see what the pathologist has determined is the primary site. Instruction 15 has been updated on coding female GYN sites when there is a decision between ovary, fallopian tube, or primary peritoneal, and there is no clear designation of origin. If there is any indication that fallopian tumor is involved or it is a specific histology that would be tubal, then code the primary site to fallopian tube. In the absence of tubal involvement, refer to the histology and treatment plans to help you determine the primary site. And when all else fails, code to C579 as a last resort. Instruction 16 for primary site. This is a table that assists us to code the primary site in the absence of any additional information. There were 2 sites that were added. So if all that you have is that it's periclitoral, then we code this to C511. And if all we know is uterovesical junction or UVJ, then we code it to C669. One code had a change, and that was the paranpharyngeal space. We are going to code that now to C139. Previously, we were instructed to code it as C490. So parapharyngeal space is now C139. When it comes to reportability, high-grade dysplasia of colorectal sites are not reportable, although the WHO Blue Book classification has them designated as in situ or /2 behavior. This is still not reportable for SEER. In ambiguous terms, under diagnostic for malignancy or reportable diagnosis, there was a phrase added to be reportable when no other information is available, and that is in keeping with. So if you have in keeping with malignancy or other reportable diagnosis, then this is considered reportable. For the data items, diagnostic confirmation and behavior, the histology intraductal papillary mucinous neoplasm with high-grade dysplasia 8453/2 of the pancreas can be based on imaging alone. If this is diagnosed via imaging, then the diagnostic confirmation should be code 27. There is a new instruction 8 stating this information specific for this histology and this primary site. This again is an exception to the rule for pathologic examination for in situ behavior, and this histology doesn't need that histologic confirmation to be coded as in situ. Again, this is not clarified in the STOR manual, so you need to follow these rules for this site and histology. So both diagnostic confirmation would be a 7, and the behavior would be coded as in situ or a /2 for this specific code if it is diagnosed based on imaging alone. For SEER site-specific factor 1, which is the HPV status, this is different than the SSDI data item for HPV or P16. For SEER site-specific factor 1, HPV is based on tissue or pathologic specimens. The SSDI is based on blood or lab reports. The codes have been updated as well from a 1-digit to a 2-digit code, codes 10 through 99. For this data item, codes 10 through 51 are hierarchical, with 10 being the highest, 51 being the lowest. The coding instructions have been modified as well. They are on this slide as well as in the manual. I want to point out 5 and 6. Those cases that are in the oropharynx, HPV mediated or P16 positive schema. If additional HPV testing is done in addition to P16, code those test results. If there is no additional HPV testing done, code 11 in this data item. Your schema discriminator 2 should also be coded to 2 as well if you code this as 11. For cases in the oropharynx that are P16 negative, if additional HPV test is done in addition to P16, code those results. If there is no HPV testing done, then it will be based on your schema discriminator 2. If your schema discriminator 2 is code 1, then your SEER site-specific factor 1 will code to 10. If your schema discriminator is 2, your schema discriminator 2 is code 9, then your SEER site-specific factor 1 is coded to 99. These are the updated codes for SEER site-specific factor 1. Data item for HPV status. As a reminder, these are based on tissue or pathologic specimens and not the same as the SSDI for HPV or P16. So here we have HPV is negative or positive based on P16 test alone. Those are codes 10 and 11. If it's based on viral DNA on an ISH test, it's codes 20 or 21, whether negative or positive. If it's viral DNA based on a PCR test, it's codes 30 or 31, whether they are negative or positive. If it's based on an ISH, I6 ISH E6 or E7 RNA test, whether negative or positive, it's codes 40 or 41. And if it's HPV by RT-PCR E6, E7 RNA test, then those are codes 50 or 51, whether they're negative or positive. Codes 70 are when the HPV status in the medical record states negative, but you don't know the type. And for 71, it's when the HPV status is reported as positive, but you don't know the type. If the test is not done, or I'm sorry, the test is done and their results are not in the chart, code 97. If it's not documented in the medical record, or the HPV test was not done, not assessed, or you don't know, code 99. Date therapy initiated has a new instruction 2 that aligns with the STOR 2024 guidelines to record the date the decision was made for active surveillance or watchful waiting. This includes cases where a patient later changes their mind and opts for additional treatment. A reminder that treatment status should also reflect the choice of active surveillance or watchful waiting, and that would be coded as a 2. So we now have this new instruction code 2, beginning with cases diagnosed 2024. If the patient opts for active surveillance or watchful waiting, we need to code the date that that decision was made, and our treatment status should reflect that as well as with the code 2. So even if the patient later changes their mind and opts for additional treatment, if that first decision and was carried out was active surveillance or watchful waiting, we code that date as the date therapy initiated. So that is a change from previous years. Again, this begins with cases 2024 and forward. For radiation treatment modality in regards to radioembolization, this aligns with instructions in the STOR 2024 manual as well. This is to be coded to 13, radioisotopes NOS. So we need to make sure that we are coding radioembolization as code 13, radiotypes NOS. And this can be done for cases diagnosed prior to 2024, but there's no need to change anything else moving forward. So radioisotopes, radioembolization, code 13. Code 82 has been updated to include progression of tumor prior to administration of systemic treatment, as well as instruction 7C was added to chemotherapy, that code 82 includes progression of tumor prior to administration as a reason why treatment was not administered. These do align with the STOR 2024 manual. So again, code 82 for systemic treatment has been modified. It now also lists that it was not recommended or administered due to risk factors, and one of those would be progression of tumor prior to receiving the treatment, and that's why they didn't receive the treatment, code 82. For the data items, neoadjuvant therapy and neoadjuvant therapy clinical response. For instruction 1, assigning code 0, this information on the slide that is in bold, when the primary site is unknown and neoadjuvant therapy is given to treat another site, has been added. So when a primary site is unknown and neoadjuvant therapy is given to treat another site, we code 0. An example here is patient is diagnosed with melanoma in the lymph node with no primary skin site found. The physician gives immunotherapy as neoadjuvant therapy with planned and carried out surgical resection of involved lymph nodes following completion of immunotherapy. For other therapy, this data item for instruction 2 when assigning code 1, and this is in regards to PUVA and UVA treatment for melanoma and cutaneous T-cell lymphoma. A note was added, and this note states that code UVB phototherapy for mycoses fungoides as photodynamic therapy under surgery of primary site 2023 for skin. Assign code B110 when there is no pathology specimen. We are now going to look at Appendix C updates to coding guidelines and surgery codes. The coding guidelines in Appendix C that have been added or updated are anus has been a new addition, and we will go over this in the next slide. Also, brain CNS, both the malignant and the non-malignant, has a new section on the tentorium. The breast coding guideline now has a statement on coding primary subsite, and the pancreas has a statement now on coding the primary site neck of pancreas. So the new coding guideline we have for anus is this illustration that will assist us to appropriate coding the primary site. So anus NOS is coded to C21.0. The colloquiogenic zone C21.2 is the area that is noted here in number 1. The part that is for anal canal, C21.1, is noted here in number 2. This is the squamous epithelium or mucosa. It's the last portion of the GI tract. It's about 3 to 4 centimeters long. And then for number 3 here, we have the anal margin, and it's actually coded to skin, C44.5. It sits below the perianal or below the anal verge. It's known as the perianal skin. So we have the colloquiogenic zone is up here with the epithelial transitional cell zone, 6 to 12 millimeters above the dentate line. So the dentate line is right here. It divides the colloquiogenic zone and the anal canal. The anal canal is this largest portion of the GI tract. And then outside of that, once we pass the anal verge, we are now in the skin, C44.5. So be sure to use this information and this illustration when you are abstracting anal cases. A footnote was added for pancreas neck, this little caret here that is in bold for coding primary site C25.7, which is other specified parts of pancreas. This includes neck of pancreas. The new note we have here is its pancreas body versus neck, letting us know the location of the neck is between the head and the body, which is where I have our little box here and our arrow showing this kind of area is where it sits. It's about 2 centimeters wide. It lies mostly behind the pylorus of the stomach. It's also located in front of where the portal vein is formed, and it is covered with peritoneum. The splenic artery and vein run along the posterior wall of the neck, and the superior mesenteric artery lies medial to the neck. So this is a very dangerous area for having a cancer and them needing to do surgery. So again, neck of pancreas giving us a little more clarification of where this is in regards to the anatomy of the pancreas. When it comes to coding breast, there were a few updates for subsite coding. Again, these are just general guidelines. When we need more information, it's not available in the medical documentation. So if we have a specific quadrant, so that falls C50.2 to C50.5, those are preferred over coding it to central breast, C50.1. So if you have a specific quadrant, use that over coding C50.1. Now, if we have nipple areola involvement, C50.0, or it states central breast is what we have, C50.1, these are preferred over an overlapping code, C50.8. So make sure you use this information as well when you're trying to determine the subsite to code for breast. When it comes to the coding guidelines for brain CNS sites, this is for both malignant and non-malignant histologies, so our benign and borderline. This is a section that is now included in the guideline on the tentorium. The cerebellar tentorium or tentorium cerebelli, this is also Latin for tent of the cerebellum. This is because it has a tent-like shape that protects the cerebellum and brainstem from the pressure caused by the heavier upper part of the brain. The tentorium separates the cerebellum from the cerebrum. The infratentorial region are those below the tentorium, and the supratentorial regions are those above the tentorium. Noted on the slide as well as in the guidelines are the subsites for each region as noted in Summary Stage 2018 manual. So the red dividing line, that is the tentorium. Anything above that line is supratentorial. Anything below that is infratentorial. For surgery coding, we will now go into these surgery codes that are found in Appendix C. The bones are the C40 through C41-9 codes. Peripheral nerves or autonomic nervous system, which is the C47s, and soft tissue, which is the C49s. Then this is some new added notes for surgery codes. For A250 and A260, a new SEER note was added stating that according to the COC, excision in the surgery codes to the lesion and partial resection refers to the organ. So A250 is a local excision. This is talking about the lesion or the tumor itself being excised. Partial resection is referring to the organ. So this means that part of that organ involved was resected. A300 also has a SEER note added. We assign code A300 when the tumor was excised and the limb was saved, which is salvaged. So an example of this is a 6 centimeter sarcoma excised from soft tissue near the distal humerus, able to obtain 2 centimeter pathologic margins. Pathologic team intercepted to perform graft with muscle taken from abdomen. They saved the arm. They did not remove this patient's arm for this. These are the breast surgery codes that have been updated. Codes that are updated typically begin with a B code, and these on the slide are not the entire listing of surgery codes, but I wanted to go through a few of these and point out some notes that are necessary. So if you notice, these are the partial mastectomies or lumpectomy or excisional breast biopsy codes. For B200, note that this is partial mastectomy, lumpectomy, segmental mastectomy, or tylectomy. Any of those occurred, and we have a previous or a preoperative positive biopsy. This means this patient we know has breast cancer before we perform this surgery. So that was based on either core or FNA. For B210, the excisional breast biopsy, this is used when there's no preoperative biopsy. The patient is diagnosed based on this excisional biopsy. They remove the mass and we find that they have cancer. B215 is an excisional breast biopsy, but they're doing this because there is atypia. We know that the patient has either a typical ductal hyperplasia or some type of atypia, and that is why the excisional breast biopsy was performed. And this excision diagnoses the patient with either in situ or invasive cancer. B240 is a re-excision from a primary tumor, so this is for gross or microscopic residual disease. It is less than a total mastectomy. So this is when a patient has a residual disease and we need to go back in and re-excise to get clean margins. And then B290 is a central lumpectomy. Again, this is only performed when there's a prior diagnosis of cancer. So the patient we already know has cancer. They are now coming in for a central lumpectomy, and this is the removal of the nipple areolar complex. This table I call the sparing mastectomy codes. All of these are some type of sparing mastectomy. A Goldilocks mastectomy is essentially a skin-sparing mastectomy with breast reconstruction, and codes B300 through B320 are usually the best available choices. B300 through B320 are the skin-sparing mastectomies, whether or not the uninvolved contralateral breast was removed. This removes all breast tissue and nipple areola complex, but preserves the native breast skin. Again, it can also be with or without a sentinel lymph node biopsy or lymph node dissection. B400 through B420 is the nipple sparing mastectomies, again, depending on if the contralateral breast was removed or not. These surgeries remove all breast tissue, but they preserve the nipple areola complex, and the breast skin, again, can be with or without lymph node biopsy or dissection. The choice between codes 300 to 320 and 400 to 420 depend upon the extent of breast removal and contralateral breast removal. You want to review the op report carefully and assign the code that best reflects the extent of the breast removal. Even if they are given a Goldilocks mastectomy, it may be a little bit different, and those may not fall in that 300 to 320 range. Again, you want to review your op report. Now the codes B500 through B520, again, very similar to the 300s and the 400s. And again, you want to make sure that we are coding what occurred. With this one, an areola sparing mastectomy removes all breast tissue and nipple, but it preserves the areola and breast skin. Performed with or without a sentinel lymph node biopsy or axillary lymph node dissection. Now, if a patient has an excisional biopsy followed by an areolar sparing mastectomy during first course therapy, code the areolar sparing mastectomy. You want the cumulative results. So make sure that you are paying attention if you have some type of sparing mastectomy performed. Review the op report and be sure that you are using the most accurate surgery code for that procedure. Continue with the breast surgery codes. These are the mastectomy codes. So we have total or simple mastectomy, which removes all breast tissue, nipple, the areolar complex, along with the breast skin. This is performed with or without a sentinel lymph node biopsy or axillary lymph node dissection. These are coded to B600 through B620, depending upon whether or not the uninvolved contralateral breast was removed. Radical mastectomies, that removes all breast tissue, the nipple areolar complex, breast skin, along with the pectoralis muscle. So a much more involved mastectomy. It also is performed with the levels 1 through 3 axillary lymph node dissection. Those codes are B700 through B720, again, depending on the uninvolved contralateral breast. Now, code B760 is used when there's a bilateral mastectomy for a single tumor involving both breasts. typically this is seen in a bilateral inflammatory carcinoma situation. Code B800 is just mastectomy NOS. You cannot code it to anything else, or it is an extended radical mastectomy. So if it is an extended radical mastectomy performed, code B800. If you know surgery was performed but you don't know the type and cannot code it to anything else, use B900. Here we have the colon surgery codes that have been updated. I have orange boxes around those that are new and updated for 2024. So pay attention to some of those, and also some of these have kind of rearranged and moved around. If there is no surgery or autopsy only, or if there's a colostomy only and there's no colon tissue removed, code to B000. A local tumor excision is B200, but then we have our polypectomy codes. And those here are in pink boxes. So I'm going to point these out. We have polypectomy NOS, and that's code B260. Then we have a polypectomy endoscopic. Now this polypectomy is done during the initial colonoscopy for screening or for symptoms. And the knowledge is we don't know if this polyp is benign or malignant. So if a polypectomy is performed during the initial colonoscopy for screening or due to symptoms, and we don't know the surgeons aren't sure what this is going to be, this is coded to B280. Now, if we have a polypectomy that is performed as an endoscopic mucosal resection or dissection, this is a more complicated polypectomy. It is performed during a colonoscopy, but it is usually known to be malignant before being done, and this is code B281. Then we have the code B290, and this is for a polypectomy that's done as an open approach, surgical excision, or laparoscopically. So this is not performed with an endoscopic procedure such as a colonoscopy. That's B290. Okay, now if we had just excisional biopsy, it's not stated to be a polypectomy. We don't really have any other information. That is code B270, kind of sandwiched between all of these guys. And then if we know that we have codes B200 through B290 and electrocautery was used, then we use the code B220 to reflect that. So again, pay attention to these polypectomy codes. They're very specific, and you want to make sure you're reading the notes and all of the information that are included with those for colon sites. Here you see we have some more orange codes for the new ones for 2024 that I want to call attention to here. We have a wide local excision with tumor, or it's a local tumor resection. It may also be called a transanal resection. This is just removing the primary tumor. This is not about removing a portion of the colon or the rectum. It's just getting the tumor with some margin, and that's B291. Partial colectomy, so this is the removal of one or more colon segments, but it's less than the half of the colon removed, less than a hemicolectomy. So it's just a segment removed. If there is contiguous organ removed, we have a code for that, so B300 or B320. Now, for appendix primaries only, if we have an appendectomy performed, we now have a code for this, and that is B330. This includes incidental findings. So if some other surgery is being performed or the appendectomy is performed for reasons not associated with cancer, we still code that as B330. Now, when an appendectomy is performed, there is a removal of a short portion of the distal ileum, and we do not consider this contiguous organ removal. Okay, so it's typical for a little bit of the distal ileum to be removed during an appendectomy. It is not considered contiguous organ removal. So B330. A hemicolectomy is the removal of the total either right side or left side of the colon and a portion of the transverse colon. So this also, B400, includes extended right or left hemicolectomy. So that is B400. If you have a subtotal colectomy, so this is a total right or left colon like we have in the hemicolectomy, except this time the entire transverse colon is removed, code 401. If you have this along with a resection of a contiguous organ such as small bowel or bladder, code 410. Continuing on with colon surgery codes, we have total colectomy, and that is the removal of the entire colon from the cecum to the rectosigmoid junction, and it could include a portion of the rectum. Not the entire rectum, but just a small portion. Those are the B500 codes. A total proctocolectomy is the removal of the colon from the cecum to the rectosigmoid junction, and this does include the entire rectum. That is B600 or B610. If you have colectomy or proctocolectomy with a resection of contiguous organs, you assign this code when there isn't enough information to assign codes B320, B410, B510, or B610. This includes any colectomy with resection of contiguous organs. It's also known as an en-bloc resection, B700. And if all you know is a colon resection was performed, colectomy, NOS, use code B800. So now let's look at the lung surgery codes. We have local tumor destruction, NOS. These codes are the B150s, B120, and B130. No pathologic specimen is sent with these codes, okay? They are just removing the tumor, killing, heating up the tumor, but without sending a pathologic specimen. So this could be a laser ablation or cryosurgery, that's code B20. If it's electrocautery or fulguration or hot forceps, that's B130. If a radio frequency ablation is performed in RFA, use code B150, local tumor destruction NOS. Now we have another local tumor destruction NOS procedure, but a different code. That's B190. We use B190 when we don't know if a specimen was sent to pathology. Now the B200 codes, they've been reordered for alignment so that the numbers are in numerical order. So previously, wedge resection and segmental codes B210 and B220 were at the bottom of the list. Now they've moved up to the top. Again, there's real no difference. It's just numerical realignment. So this is excision or resection of less than one lobe, which could be wedge resection, which is B210, segmental is B220, excision NOS is B230, laser excision is B240, and bronchial sleeve resection only is B250. Again, these are less than a lobe, same descriptions, just different numerical ordering. Continuing with lung surgery codes, we now have the B300s. This is a resection of a lobe or bilobectomy, but this is less than a whole lung. This is where we are removing one or more lobes of the lung, but not the entire lung. Now, if a mediastinal lymph node dissection is performed, use code B330. If a lymph node dissection is not performed, but they do have lymph nodes that end up being obtained as part of the lobectomy, we need to code that as B300, not B330. We need to make sure that a mediastinal lymph node dissection is what was prepared for, what was planned, and what was carried out to code B330. For bronchial sleeve lobectomy, This is an entire lobe or lobes removed in addition to a part of the main stem bronchus. Now, this is not typical or standard lobectomy or bilobectomy. So that's not typical for this to occur. So if you have a portion of the main stem bronchus removed with a lobectomy, be sure that you are coding this to bronchial sleeve B320. And then we have B450 through B480, and this is a lobe or bilobectomy that is extended, again, less than an entire lung. But if any of these other sites were removed with that, be sure that you are coding this accurately to show and reflect those additional sites being resected as well. And the last bit on the lung surgery codes here, we have the pneumectomy codes. So we have pneumonectomy NOS, and that is B550. Some other names for this is complete pneumonectomy, sleeve pneumonectomy. This is the resection of the whole lung. This is an entire lung removed. If there is mediastinal lymph node dissection, also known as a radical pneumonectomy, this is code B560. If you have an extended pneumonectomy NOS, that's B650, and this is a resection of the entire lung in addition to one or more of the following, either superior vena cava, left atrium, aorta, or chest wall. That's B650. Now, if they also take the pleura or the diaphragm, that is B660. Now, extended radical pneumonectomy, that is our old code A700. We have no corresponding B code for this, and we are told to code an extended radical pneumonectomy to B660. If we have a resection of the lung and it's not classified in the previous codes, code to B800. For pancreas, we had a few updates and specifications here, but really not a lot of description changes. We'll point out that we have local tumor excision where there's an enucleation or laser tumor destruction or ablation, that's B250. If we have a partial pancreatectomy, so a distal pancreatectomy or subtotal pancreatectomy, that's B300. If you have a local or partial pancreatectomy and duodenectomy, this is also known as a Whipple procedure or a pancreatico-duodenectomy. That is B350. Without the distal or partial gastrectomy, so this is a pylorus preserving Whipple, that is code B351. With a partial gastrectomy, this is a classic Whipple, that's B352. If they don't specify where the stomach was cut, then code it to B350. So if we don't know if there was a gastrectomy performed, code B350. A total pancreatectomy is B400. An extended pancreatoduodenectomy, which was previously code A700, is now B600. So this includes total pancreatectomy and subtotal gastrectomy and or duodenectomy. And pancreatectomy NOS is B800, and surgery NOS is B900. And if a nanoknife or irreversible electroporation or IRE is performed, that is code B900. For thyroid surgery codes, they were also, none of the descriptions or notes were really changed. It is, again, a numerical listing has been reordered into ascending order. So removal of less than a lobe NOS B200, local surgical excision is B210, and removal of a partial lobe only is B220. Now, if we have a lobectomy and or aesthectomy, that is a B250. If we have lobectomy only, either right or left, so we are removing a full lobe of the thyroid, that is a B251. If we're only removing the isthmus, that is B252. And if we have a lobectomy with the isthmus removed, that is B253. Then we have the other codes where it's removal of a lobe and partial contralateral lobe, B300, a subtotal or near total thyroidectomy, B400, and total thyroidectomy, B500. And if you don't have any of the above, you just know a thyroid surgery was performed, a thyroidectomy, B800. All right, now we want to look at some changes and updates that occurred to Appendix D for race and nationality coding. The real big changes are that the references have been updated. So on some of the codes, we are to see the references. So make sure that you are using the most updated Appendix D and using the most updated reference. You want to only use these lists when race is not stated, but you have other information provided in your medical record. So code 03 for American Indian and Alaska Native, we are told to see reference 2 for the most updated list. For code 98, other race not elsewhere classified, it tells us do not use for Hispanic, Latino, or Spanish NOS. We need to refer to reference 1. And for code 99, unknown, we need to see other race descriptions. So the descriptions of ethnic origins cannot be coded to a specific race code. They are listed for code 99. Again, refer to Appendix D when the race is not stated, but you have other information in your medical record. Appendix E, which has our reportable and non-reportable examples. So Appendix E1, the reportable examples on line 23, exceptions were added and noted here in the orange box. Though these exceptions have been added as part of reportable examples, but these are not reportable. So make sure these are not reportable for SEER. For Appendix E2, non-reportable examples, so we have on line 1, we had some updates here, just some revised diagnosis and conditions noted. This has to do with sclerosing pneumocytoma of the lung with multiple regional lymph nodes. So it goes to tell us that most of these begin or behave in a benign fashion. However, although those cases with lymph nodes, metastasis, and distant organ have occasionally been reported, these do not appear to adversely affect prognosis. So these are considered non-malignant. Lymph node involvement with sclerosing pneumocytoma is non-malignant. So we are not reporting these, as well as any high-grade dysplasia in sites other than stomach, which we've already discussed earlier in the presentation. So if high-grade dysplasia is in sites other than stomach, small intestine, and esophageal, they are not reportable. Again, this wraps up the presentation on the SEER program coding, manual, and staging. So if you have questions, as always, you can search your topic and question on SEER Sync, or submit a question to ask a SEER registrar, or reach out to the Iowa Cancer Registry to myself or Bobby Mott. And I appreciate your time and attention during this presentation.